Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
The purpose of this podcast is to educate and inform. This is not a substitute for medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.
Hello, and welcome to part 2 of ASCO Education Podcast on new therapies for lymphoma. My name is Dr. Sonali Smith, and I'm a hematologist and medical oncologist specializing in lymphoma and clinical trials for lymphoma. I am also the Elwood V. Jensen Professor and Chief of the Hematology and Oncology section at the University of Chicago.
Hello to everybody. I'm Dr. Paolo Strati. I'm a hematologist and medical oncologist and assistant professor in the Department of Lymphoma and Myeloma and in the Department of Translational Molecular Pathology at the University of Texas and the Anderson Cancer Center in Houston, Texas. In part 1 of this podcast episode, we discussed recently approved therapies for diffuse large B-cell lymphoma. And today we will be exploring instead new therapies for follicular lymphoma and new therapies for mantle cell lymphoma.
Wonderful. So we are going to start off today with a discussion about a patient case. The individual is a 55-year-old woman with previously untreated follicular lymphoma, low-grade advanced stage, and low tumor burden and low FLIPI. She was diagnosed 3 years ago and had observation, but more recently developed a 7-centimeter retroperitoneal mass with impending ureteral compression and no PET-C concern for transformation, specifically with an SUV max of 5.3. Despite this radiological finding, the patient had a performance status of 0, no symptoms, no significant comorbid health conditions, and was given R-CHOP times 6 cycles, followed by achievement of a CR. She was then observed, but unfortunately, 18 months later, the PET-CT showed diffuse low FDG uptake adenopathy, and a lymph node biopsy was repeated. This showed a follicular lymphoma relapse. So, Dr. Strati, tell us a little bit about your approach to follicular lymphoma in the initial setting. Do you consider Guelph criteria? And how do you select second-line therapy in this patient? Does the early progression of disease within 18 months, she falls into the category of POD 24, the progression of disease 24 months. How does this affect your treatment choice going forward?
Thank you, Dr. Smith. Those are all very good questions. So going to your first question, we typically use Guelph criteria, as you know, developed in France now many years ago, mostly at time of initial diagnosis. And that's to determine whether a follicular lymphoma patient does indeed have an indication for treatment. And these criteria, as you know, are based on lymph node size and number, organomegaly, cytopenia. However, it's still debated whether this should also be applied at time of relapse. And in this particular case, a patient, as you said, had what we call a POD 24 or progression of disease within 24 months from initiation of chemoimmunotherapy. Given the suboptimal outcome of these patients, I think that it would not be unreasonable to treat these patients even if they don't formally meet Guelph criteria, so even if they don't have formal indication for treatment at time of relapse. Once the decision is made, standard second-line options for patients with follicular lymphoma currently include chemoimmunotherapy. So if the patient received R-CHOP in frontline, would be BR, or if they receive BR in frontline, of course, R-CHOP. But also immunotherapy with R-square, so rituximab, Revlimid, or lenalidomide. Single agent anti-CD20 monoclonal antibody, or obinutuzumab, which is specifically approved by the FDA in the United States for rituximab refractory follicular lymphoma patients. And in very selected cases, and this is still open for debate, high-dose chemo with a platinum-based agent, followed by autologous stem cell transplant. We don't know at this time what's the ideal second-line strategy for patients like the one that you described in your case, so follicular lymphoma patient with POD24. And to this regard, all are very eagerly awaiting the results of an ongoing SWOG trial, 1608, which is a randomized phase 2 study comparing in second-line chemoimmunotherapy, immunotherapy, and also PI3 kinase inhibitor for this patient with POD24. Finally, one thing which I think is important to consider is that even if R-square is not currently approved by the FDA in the frontline setting in the United States, and actually is not approved at all in Canada, in Europe as a frontline treatment, in the United States it's possible to use it in frontline thanks to NCCN guidelines. And over the last few years, its frontline use in our country has actually meaningfully increased. This is creating a new clinical scenario that we never met before. And there are no standard second-line options currently established for these patients who receive frontline R-square, emphasizing the need of translational research to understand more of the biology of patients who relapse after frontline R-square, but also emphasizing the need to mostly look into clinical trials when these patients unfortunately experience a relapse.
Yes, thank you, Dr. Strati. I agree. I think that it is, the way that frontline follicular lymphoma and in the relapse setting exists is that we have a toolbox and no real clear data on how to personalize the therapy. So your, comment about needing some better translational work to fine-tune the clinical trials is really important. So for this patient, though, she did receive R-squared for 12 cycles and achieved a complete remission after 6 cycles. 12 months later, a PET CT showed diffuse low-level adenopathy, low level meaning low uptake on a PET scan, and she had another lymph node biopsy. This showed persistent follicular lymphoma. So now, how do you select your third line option, knowing that we have biologic therapy as well as cellular therapy available to this patient?
So going back to the metaphor that I used before, we have a very nice toolbox also in third line, but also in third line really no strong, robust translational data to drive us when it comes to treatment selection. Agents currently approved by the FDA in the United States as a third-line standard option for patients with relapsed refractory follicular lymphoma include, as you alluded, PI3 kinase inhibitors, currently 3, copanlisib, duvelisib, and idelalisib, and an EZH2 inhibitor called tazemetostat. The 3 PI3 kinase inhibitors currently approved in third line have very similar efficacy with a response rate of 50% and a median progression-free survival of about 10 months. And the selection among the 3 is typically based on toxicity profile, which is more on the autoimmune side for duvelisib and idelalisib, and more on the metabolic side with hyperglycemia and hypertension for copanlisib. Also, one element that in my experience is typically used to select one of these 3 is the route and the frequency of administration. Because we have to remember that idelalisib and duvelisib are both given orally twice a day, whereas copanlisib is given intravenously 3 times a month. And so, of course, different patients may have different preferences. As a matter of fact, though, the use of PI3 kinase inhibitors for relapsed follicular lymphoma in the United States, and I would say also in other countries, is quite limited, mostly due to toxicity and relatively limited efficacy. Tazemetostat, the EZH2 inhibitor that I mentioned previously, has a response rate that can vary between 30% and up to 70%, significantly higher in patients who do have a documented EZH2 mutation. But the median progression-free survival is about a year, no matter whether the mutation is present. So not that different from PI3 kinase inhibitors in the same setting. Of interest, given the short duration of response, we may consider these agents as a bridging therapy for follicular lymphoma patients. We instead proceed with CAR T-cell therapy because, as you mentioned in your question, CAR T-cell therapy, and specifically axi-cell, has been recently approved by the FDA as a third-line option for patients with relapsed refractory follicular lymphoma based on results from the ZUMA-5 study. It's important, however, to emphasize that axi-cell has shown better efficacy and safety data in follicular lymphoma patients as compared to large B-cell lymphoma patients than we discussed in the previous episode of this podcast. And as such, axi-cell may potentially represent a curative option for patients with follicular lymphoma, a condition that historically has been considered incurable. T-cell, another CAR T-cell product targeting CD19, currently approved by the FDA for large B-cell lymphoma, but not yet for follicular lymphoma, may also be soon approved by the FDA for patients with follicular lymphoma based on the ELARA study. And we're all eagerly awaiting the results of this study and potentially its approval in the next few months.
That's great to hear. And, hopefully we will continue to have more options, including more cellular therapy options for patients. So this particular patient proceeded with the standard of care Axi-cel that went quite well. There was only grade 1 cytokine release syndrome, no neurotoxicity, and the patient achieved a complete remission on both the day 30 and the day 90 PET CT. Unfortunately, there was relapse 6 months later. So what standard options are there at this time? And would you consider an allogeneic stem cell transplant at this point?
So I have to say that based on Zumafy data, I'm not surprised this patient did quite well in terms of safety. And I'm very sorry to hear that was one of those few patients who relapsed after initial complete remission after Axi-cel. In fourth line, our options are a little bit more limited. The FDA has recently approved in fourth line for patients with relapsed refractory follicular lymphoma a new PI3 kinase inhibitor called umbralisib. For umbralisib, response rate is quite similar to other PI3 kinase inhibitors, about 50%. However, the median progression-free survival, that as I mentioned before, is about 10 months for the PI3 kinase inhibitors currently approved in third line. Instead, has not been reached yet at 2 years for umbralisib. And also the toxicity profile seems to be more limited, though similarly to idelalisib and duvelisib, more on the autoimmune side. Therefore, definitely umbralisib would be an interesting option for the patient case that you described. As for your second question, the possibility to use allogeneic stem cell transplant for patients with relapsed refractory follicular lymphoma, retrospective studies have shown that allogeneic transplant is effective in follicular lymphoma patients, particularly those with POD24, like the patient that you described in this scenario. But the transfer-related mortality is significant and needs to be taken into consideration. But most important of all, as CAR T-cell therapy has been approved for follicular lymphoma very recently, we really have no data regarding the use of allogeneic stem cell transplant in follicular lymphoma patients who relapse or progress after Axi-cel and CAR T-cell therapy in general. This last statement really applies to any approach, as again, Axi-cel has been approved for follicular lymphoma only within the last 12 months. And this, once again, emphasizes the importance of translational research and clinical trials for these patients. And as such, I think that along with umbralisib, that is a standard option, clinical trials are definitely the best option for patients with follicular lymphoma whose disease it's either refractory or relapses after CAR T-cell therapy.
Yes, thank you for these insights, Dr. Strati. I agree. The post-cellular therapy or the post-CAR T space is a very challenging situation, and I appreciate your perspectives. So as an update, this patient received umbralisib for 6 months and had an initial response with a partial remission, but eventually progressed and then proceeded to a clinical trial now on a novel oral immunomodulatory agent and has been in a complete remission for 4 months.
That's great to hear, and I hope that this remission will be durable, emphasizing again the importance of clinical trials for patients with lymphoma in general, and particularly those who relapse or are refractory to standard treatments. It was very interesting to listen to this case. Thank you for asking your question, Dr. Smith. I'm going to ask your opinion now about a second case. This is a 67-year-old man with diabetes that has a long-lasting history of rectal bleeding, for which he underwent a colonoscopy in 2016 that revealed hemorrhoids and scattered polyps that were non-malignant on biopsy. However, as part of routine follow-up, a colonoscopy was repeated 5 years later, and this unfortunately showed diffuse nodularity of the colon with several areas of ulceration. Biopsy of the nodule showed a mature B-cell lymphoma, CD20 positive, CD5 positive, BCL2 positive, SOX11 positive, but negative for CD10. FISH testing confirmed the translocation 1114. There was no evidence of TP53 mutation, and Ki67 was 40%. So, Dr. Smith, what do you think about the overall potential histological diagnosis, and how do you approach this patient in terms of staging and prognosis discussion?
Yes, so this poor patient, with longstanding rectal bleeding, I mean, this can happen. It's not a very common presentation for mantle cell lymphoma, but we know that mantle cell lymphoma is very likely to involve the GI tract and can often be extranodal. In terms of the histology itself, this is very classic. The co-expression of CD20 along with CD5 is only seen in CLL and mantle cell lymphoma. And in this case, the mantle cell lymphoma is confirmed by SOX11 positivity, CD10 negativity, and then also, of course, the FISH showing translocation of 1114 with a cyclin D1 overexpression. When it comes to prognosis in mantle cell lymphoma, there's a number of different prognostic indices, but the two biologic features that I think are most important are P53 status as well as the proliferation rate. Patients who have a TP53 mutation typically have chemo-resistant disease, and we have no really good approach in terms of how to treat these patients the best.
Thank you, Dr. Smith, for outlining the diagnostic and prognostic approach to patients with mantle cell lymphoma. You alluded in your answer about the heterogeneity of treatments. So I wanted to ask you, how do you in general treat patients with mantle cell lymphoma, and more specifically this case? And also, we keep dividing patients with mantle cell lymphoma in transplant eligible and ineligible. But the big question is, do all patients who are transplant eligible need transplant? And what's your overall approach to this major dilemma?
Yes, that's a really good question. The general approach to treatment for mantle cell lymphoma is based on the concept of fitness and age. So we end up dichotomizing patients into one of two groups. They are either young and fit, or they are older and unfit. And of course, this is somewhat controversial because age itself is just a number, and there is significant variability based on function and other medical conditions. Complicating that further is that many clinical trials have used 65 as the arbitrary cutoff between young and old, whereas some transplant studies have actually gone all the way up to age 70. So, if I focus on the fact that this is a 67-year-old man who has no real significant history and clearly has a disease that needs treatment, my general approach has been to follow the younger and fit approach. And as you mentioned, the historical approach to this has been to think of treatment in three phases. There is induction, there is consolidation with a high-dose chemotherapy and autologous stem cell transplant, and then there is maintenance rituximab for 3 years, which has been shown to have a survival advantage. But your question, I think there are many unanswered areas when it comes to approaching a patient who is going to be treated with an aggressive, multimodality approach. So first, in terms of the induction itself, there is data that cytarabine-based regimens likely achieve a deeper minimal residual disease state than alkylator-based therapy. And so cytarabine-containing regimens have really become the standard of care against which other regimens are compared. That being said, there was at least a SWOG study that randomized patients between BR and hyper-CVAD and found that BR was a sufficient type of induction. And some of this controversy led to an ongoing intergroup trial, which is EA4181, that takes patients with newly diagnosed mantle cell lymphoma, previously untreated, like our patient, and randomizes them to bendamustine rituximab with or without cytarabine and with or without a BTK inhibitor, in this case, acalabrutinib. So they're, outside of a clinical trial, I would use a cytarabine-based induction regimen, but I have preferred to put most patients onto that. But your second question, which is, do all patients need high-dose chemotherapy and an autologous stem cell transplant, is really important. This is associated with a need for inpatient admission, high-dose chemotherapy with subsequent late toxicity, and remembering that mantle cell lymphoma remains an incurable disease, the question is whether or not all patients should get this. So to address this, there is the EA4151 trial, which is also being done through the United States Intergroup. And this is using a very unique minimal residual disease assay to randomize patients to either transplant plus maintenance or maintenance alone. And so this is a next generation sequencing test. And if patients have a negative MRD status at a very deep level, then patients will get randomized to one of those two arms. Whereas if they have minimal residual disease that is detectable, then they will go ahead and get the standard of care. So for this patient, he opted to be on the clinical trial and was randomized to BR plus cytarabine plus acalabrutinib. But outside of a trial, I really would have considered intensive induction, including the Nordic regimen that includes high-dose cytarabine, followed by transplant and maintenance rituximab. Now, some may argue with me that this person is 67 years old and the Nordic regimen is quite intense. And I think this is where some of the art of medicine may come in, and hopefully we can have some type of assessment tools to better predict who can tolerate intensive induction. But I am quite impressed by some of the transplant data that do lead to 7 and 10-year remissions in some cases. Of course, this new trial will tell us whether or not we're overtreating many of the patients, particularly based on their MRD status.
Thank you, Dr. Smith. It was very helpful. I think you outlined really well how challenging it can be to treat patients with mantle cell lymphoma and how important it is to tailor treatment based on biological but also patient-related data. This is all that we have for today. Thank you, Dr. Smith, for a very delightful conversation. It's been very helpful to review together today the treatment of patients with follicular lymphoma and mantle cell lymphoma and safety and efficacy of novel therapies for these patients. Thanks, everybody, and particularly thank you to all the listeners who tune in to this episode of the ASCO Education Podcast. And thank you, Dr. Smith, for your time.
Thank you. It was such a pleasure to have this conversation today.
Thank you for listening to this week's episode. To make us part of your weekly routine, click subscribe. Let us know what you think by leaving a review. For more information, visit the Comprehensive e-learning center at elearning.asco.org.